and some 20 to 30 patients, 30% of the patient may not respond to, they fail, the thrombolytic therapy may fail in some. So sometimes, now the last 5 to 6 years, we are doing primary angioplasty. So primary angioplasty is preferred to thrombolysis these days because it has got much better results than. So anybody coming acute MI within the window period, if the hospital has that facility of primary angioplasty, you have to do angioplasty. Primary angioplasty, it is completely reversible. You can reverse the MI. Whereas here in stroke, it is in minutes. Here it is, the heart has a toleration capacity for a couple of hours. So angioplasty, you do angiogram, and wherever you find a block, if that is causing a block, some 80%, usually 50%, up to 50% of block, usually patient will not have any symptom. This is called silent coronary artery disease. Only when above 50% symptoms might come, and the plaque rupture and all will take above 50%. So angioplasty means do angiogram, we go to the culprit vessel, we dilate it wherever the thrombus is there, we dilate it and put a stent, and the flow is re-established. So that is the angioplasty. I wanted to show some today. So that is the treatment for that. And then what is the if there are three arteries, right system, left system. Left is the left main coronary artery, divides into left anterior-descending, left circumflex. Right coronary artery comes down, continues behind as a posterior descending artery. So these are the three main arteries: LAD, LCX, and RCA. So it depends on how many vessels are involved, and each vessel has how many blocks, how big is the block. So your decision on the table. Patient is lying down there in the cath lab, you are doing angiogram. Now you have to see how many vessels are involved, how many blocks, how big is it. Then you have to take decision immediately. And this is all big money involving us. Suddenly patients, family members are in a shock. And when you tell them to get 2 lakhs, 3 lakhs, 4 lakhs, it's a big shock for the family members. It's not a small thing. So talking to patient, convincing them, everybody will not have money. That is a big headache. Every day we have about 10 MIs in our hospital. 10 MIs. So convincing the patient, explaining them. Some people misunderstand us. They think that we are just telling lies for money's sake. So these are the part of our profession. So you should be able to convince the patient and show them that this is such and such thing happened. If time is wasted, the infarct occurs and there will be permanent scar on the heart, and this patient will have recurrent arrhythmias and heart failure, and they may die in 5 to 6 years. So that is the dangerous thing. So, and people who have non-stentable lesions, suppose in LAD there are 4 lesions, proximal, middle, distal, 3 or 4 lesions. You cannot put 3, 4 stents. Maximum 2.2, you can put 2. But then it's a highly risky. So you're playing with a vital vessel, especially when you're not allowed to touch the LMC, left main coronary. If left main coronary artery is when you're handling it, if it ruptures or the thrombus takes the patient will die on the table. So therefore, some people they may require bypass surgery. People who have multiple lesions, especially diabetics. Especially diabetic, they have multiple lesions. Elderly people, multiple. Young patient, maybe they have 1 lesion. Single vessel disease, single vessel disease, or 2 vessel disease, or 3 vessel. Usually 3 vessel disease, we don't take risk. Unless the 3rd vessel is only 30 or 40, we still try to manage with a stent. But otherwise, we send the patient for bypass. Usually, when there's a left main coronary artery block or obstruction or thrombus, nothing doing, we have to send the patient for bypass. So these are the various things that we have to decide there and then on the table when patient is still on the cath lab table. So that is a challenging task for the cardiologist, daily work for them. And The doctors, the night duty cardiologist should be always on the alert. And youngsters, they are waiting for primaries to do. They want to do more and more primary. They got into primary. It's a primary angioplasty, but to look a short name. Hey, primary आ गया, बस जल्दी आ जाओ. So it's a challenging thing, and we used to enjoy a lot. I did 10 years night, 10 years night. My hospital, we had seen hundreds of patients. So what is the treatment of coronary artery disease? 10 minutes. What is the treatment of coronary artery disease? First of all, the antiplatelets, because the thrombosis main culprit is platelet. Platelets are poor platelet. They are trying to help you they're trying to repair your damage. In the process, they get aggregated, they become activated. When they become activated, they become irregular in shape, and this irregular shape gaps, fibrin, RBC, everything comes and fits, forming a thrombus. The platelets are coming with a good intention, but then if they are inviting RBC, fibrin with a big thrombus formation. So you have to give antiplatelet. You should not allow the further increase in the thrombus. So antiplatelet is the mainstay of the treatment. Number one, antiplatelet in the form of, we have very good antiplatelet in the form of a good old 100-year-old aspirin. Aspirin is very good antiplatelet. Of course, antiplatelet mechanisms are many. So second is your clopidogrel. Usually we give the combination of aspirin and clopidogrel in a loading dose to begin with. Then slowly these patients should be on antiplatelet for life. And next important drug is anti-anginal. We have many anti-anginal drugs, and especially when you are dealing with acute MI, you have also to give heparin for any prevention of any further thrombus formation. So antiplatelets and heparin is the important immediate treatment along with your anti-anginals. In the anti-anginals, you have nitrate. Nitrate, sometimes we give sublingual nitrate, which acts immediately within 5 minutes. When we were doing night duties in cardiology, ICU, all the doctors, we used to keep about 10 tablets of NT, 10 tablets of nitrates, sorbitrate. It's called sorbitrate. And this is very cheap, hardly 1 or 2 rupees. So we used to carry, whenever we are getting, we just put one tablet on the tongue and then take the next decision. So that was the thing those days. Nitrates and beta blockers. Beta blockers is another anti-anginal drug. Though they're beta blocker, they reduce the contractility, they reduce the heart rate, and they reduce the metabolic demands of the heart. After all, because the ischemia, because of demand supply mismatch with the aesthetic problem. So beta blockers do a wonderful job by reducing the myocardial demand, so stopping the further formation of the thrombus. Next another very important drug is calcium channel blocker. Calcium channel blocker, they dilate the vessel, they increase the coronary circulation, and they also increase the blood pressure if the patient has high blood pressure. And then potassium channel openers like your Nicorandil, wonderful drug. Potassium channel openers, they are also anti-anginals. The patient is having ongoing chest pain. Sometimes we also give potassium channel. The Nicorandil infusion also